Hola a todas. Hello, everyone. I'm sorry about my English. This is Dr. Gomez from Wilson Fertility in Spain. Today is a different day because we are going to have our first live transmission on YouTube in English. Okay, this is our this is the first time we transmit in live, and this is in English also. So I'm very sorry about my English. We are going to talk today about surrogacy. All right, especially in the United States. We are with Dr. Hussein Sadeh. She is a director of the Fertility Institute of San Diego. He is a specialist in gynecology and also in fertility treatments. Good night, Dr. Hussein Sadeh. How you doing there?
Good night, Dr. Gomez. Very well, thank you for asking. I hope you and your audience are well too.
Okay, thank you very much for having us, for being here. I know you are quite busy. You are in the Middle East. It's 2 p.m., right?
Yes, it's 2:01 exactly.
2:01 exactly. So it's 9 hours difference. Here is 11 p.m. So we are almost going to bed, right? But tomorrow is holidays here in Spain. So I'm going to show the beautiful that is your center here. So you are the director of let me, how you say this? Here. This is the San Diego, the Fertility Institute of San Diego. It's located in San Diego, right?
Yes.
Since when is it open? Since when is your center opened?
Since 2014.
2014, so it's quite a long way. And how many people are they working there?
We have quite a few people. Not everyone is part-time, but there's a lot of them right there in that picture.
All right, yeah. So we are looking at the people. We have met Marina, who is quite nice, and I knew you through Laura Marquesani, who is working with us in the international department here in Wilson Fertility. So Laura, hello, and a big hug for you. And then let's start from the beginning. I would like to talk about surrogacy according to the European perspective. I mean, all right. So about couples of homosexual men, gays, or a lady that has medical problems that she can carry a pregnancy, that they are living in Europe and they want to go to the center. And first, I would like you to tell us what is the term of gestational carrier and intended parents. What is the gestational carrier? What does it mean?
Thank you, Dr. Gomez. So very good questions. And intended parents for us is the people who will be raising the child or children, if it's more than one. So they are the parents raising the child. The gestational carrier is someone who carries the baby for 9 months and goes through labor and delivery. There used to be two terms. There was a traditional surrogate. A traditional surrogate, which we don't really use anymore, is someone who also gives her eggs. So her eggs are used to create the embryo, and then she conceives through donor insemination, for example, intrauterine insemination, or even IVF. But that can pose certain legal problems and issues for the baby because there is a genetic bond between the mother and the baby. And so it's been a very long time that we've actually moved away from that concept. And the term really should be gestational carrier. This is someone who has no biological connection with the baby, essentially. It is someone else's eggs, someone else's sperm that's used to create the embryo. The embryo is transferred into her uterus, and she carries the pregnancy for the 9 months. So those are, it's very important to use the correct terms, I think. Intended parents, again, the people who will be raising the child, person or people, I should say. And the gestational carrier is the woman who has no biological or genetic link to the baby, who will be carrying the embryo and the baby for 9 months.
Okay, so I would like to say a little disclaimer here. I'm working in Spain. My center is in Mallorca. I will put the name here. That's correct. Wilson Fertility, Mallorca, Spain. We are working in the Palma Planas Hospital in Mallorca, and we would like to, but we can do these treatments, even the scans, the ultrasounds. So, but my personal opinion is that in certain cases, this should be allowed in Europe, okay, and it's not permitted here in Spain. So, just to make me clear what is going. Just you are a friend of mine. I just want to share people, and I think I have friends that they have gone to the States, and the experience is being completely perfect. Okay, they have children, no problem at all, and my opinion here, my idea here will be to help people in Europe that they are planning to go to the States. Okay, they can go elsewhere, but we are talking with a doctor from California and a doctor whose specialty is fertility. You do all the treatments in fertility, right? Not only surrogacy, right? You do pickups and transfer and inseminations, everything, right?
Correct.
Okay. And then, what is the first step that they have to do? They have to connect directly to the center, and you tell them agencies that do this work. If I want to go to do surrogacy in the States, what is my first step? To go to your beautiful website that I'm gonna state again here. What is the first step, doctor?
Thank you, Dr. Gomez. So the first step is we like to see our patients. We like to do a video chat with them. We set up an interview. If you have records ahead of time, we ask that you send us the records, any testing that you've had done, so that we have as much information about you. And then during that interview that we do together, we go over the questions, your medical history, prior fertility treatments that you may have had done. And we also go through the journey that you'll be going through with respect to how it begins and where we take you until. As far as how it begins, we want to make sure that you're candidates for this. And by candidates for this, I mean that we have good enough egg quality and good enough sperm quality to be able to create embryos for someone else to carry. So if you are providing the eggs, we would like to make sure initially, before you make the trip to the US, that your egg quality testing is good enough. We would ask for an AMH level, an ultrasound for an antral follicle count. We work with our colleagues to make that easier so that you can hopefully have the tests done at your home. We ask for semen analysis as well. Once we get all of these results from you, then we will set up another video chat to go over the results and then try and plan or calendar the cycle a little better for you. If you are providing the eggs, then you will have to go through the egg retrieval. We make a calendar for you with respect to what day to be in the US and when you can expect to leave from the US. The nice thing is that everything that we need, we have at our center. We have our Quad A certified surgery center, the IVF lab. So all of your treatment will be done in-house at the Fertility Institute of San Diego. You will go through the injections. I will personally monitor you. You will always see me at every single visit in the office. We have staff that speak many languages in the office. So for most of our patients, they can speak in their mother tongue and be comfortable enough here. Our surgery center, as I said, is here in the office. I perform the egg retrieval myself. On the day of the egg retrieval, we also need a sperm source. If you have a partner to provide the sperm, we ask for a fresh sample that day. We can also make arrangements for the sperm sample to be cryopreserved or frozen in your own country and have it shipped to us if they can't make the journey with you. On the day of the egg retrieval, we physically take the sperm and we inject it into the egg with the ICSI procedure, intracytoplasmic sperm injection. And the next day, we would find out how many of your eggs actually fertilized. And I call you myself to tell you what the fertilization rates are. And then from that point on, what I call the embryo Olympics will begin. And your embryos are in the Olympics for 5 to 6 days. They have to cross the finish line, which for us is the blastocyst stage. And the reason why the blastocyst stage is so important is that at that stage, we can actually do genetic testing on the embryo. And by the genetic testing, so, the embryo has hundreds of cells in it at that stage. We have a laser, we make a cut in the shell of the embryo, take out a handful of cells, and those cells actually goes off to the genetics lab for testing. And right after that, we freeze all of the embryos that we have, and they can stay frozen indefinitely. About 5 days after the biopsy, we get the genetic testing results back. And for me personally, this is one of the most important parts of the IVF treatment cycle. So the testing is called PGTA, and it stands for pre-implantation genetic testing for aneuploidy. And aneuploidy refers to abnormal cells. So we're checking for abnormal genes in the embryo. And the technology that we use today is the latest technology, NGS, or next generation sequencing. And the beauty of NGS is that we check for every single chromosome in the embryo. And by doing so, we're assuring that we will have hopefully the highest pregnancy rates for this embryo when we transfer the embryo. Once we've created the genetically normal embryos, then either at that point you can start the search for a gestational carrier. If you're providing the eggs, we would like to make sure that we have genetically normal embryos usually. If there's a concern about egg quality before you start the search for a gestational carrier. And once we have the genetically normal embryos, we typically refer you to agencies that we work with. And these agencies, their job or their role is to recruit and find good gestational carriers. The nice thing about the gestational carrier is that you actually get to interview these people. And that's very, very important because this person will be carrying your child for the next 9 months. And I always say you should be comfortable with this person. You should have an open relationship, be able to talk about things, discuss things. So you're actually interviewing the person, and also the person will be interviewing you, the intended parents, to make sure that it's going to be a good fit. Once you choose a gestational carrier, then our job as the physicians is to make sure that this gestational carrier will be the best carrier for you, and that she can, carry the pregnancy to term with hopefully no complications. And the first thing that we do is we get the medical records. We always recommend to pick a proven gestational carrier, someone who has had a pregnancy and a delivery. And the reason why that's important is because I'll be able to get her medical records, go through her entire pregnancy course, make sure that there are going to be no potential issues in a subsequent pregnancy. Because of course our goal is to do one embryo transfer, put one embryo in, the gestational carrier gets pregnant and she's able to carry to term. So we get the medical records in, and then we do a consult with this gestational carrier so that she's aware of the entire process. And the process will involve injections for her, And the purpose of these injections is really to be able to synchronize the lining of her uterus with our embryo that's 5 days old. And we need to make sure that the uterus and the embryo are exactly in sync together, so as to maximize the implantation or pregnancy rates. And that's why she has to go through injections for a few weeks, and she comes in for monitoring. And the way we monitor her response to the medications is by doing ultrasounds. And again, I do the ultrasounds myself. We measure her hormone levels. And once the lining is thick enough and it gets to the type of pattern that we like to see on ultrasound, typically called a trilaminar pattern, then we'll start her on progesterone, and that starts the clock for the embryo transfer, which is about 120 hours later for blastocysts. The standard of care is we put back one embryo only because the pregnancy rates are so high. By adding a second embryo, we're not necessarily increasing the likelihood of pregnancy. We're increasing the likelihood of multiples.
Yeah,
So
and risks.
absolutely. Instead of 1, 2, or 3, if one of the embryos splits, then she'll have a set of identical twins and another one.
But it's quite rare. It's not very common that, okay? Because people, they ask, but it's not very frequent. So
it's
no problem.
But, you also have to consider, well, what happens if you end up with a triplet pregnancy? Because it's an extremely high-risk pregnancy. Patients go into preterm labor very early. From 21, 22 weeks, they can start to have contractions. And, our number one goal is always to keep the pregnant person as healthy as possible. And our number two goal is to make sure that we have the healthiest babies possible. And if they end up delivering prematurely at 24, 25 weeks, they can have developmental issues and lung issues because the lungs are not fully mature. So as much as possible, we recommend transferring just the one embryo.
All over the world, I totally agree. And when you do the transfer, in some cases, do you before that do some kind of biopsies or test from the endometrium to check that everything is fine, a hysteroscopy or a culture to check if you had an infection or whatever? You do the test before doing the transfer because you have so much high pregnancy rates. I think you reach 70-80% chances of getting pregnant per transfer.
Correct. So
it's amazing.
We do a thorough, and I think a couple of reasons. Number one is that these are PGTA tested embryos. Yeah. So we're eliminating the genetically abnormal embryos. We're eliminating, that associated higher risk of miscarriages with these embryos. And number two, we do a thorough evaluation. We always check initially with a saline infusion sonography or water ultrasound. If there are any issues with that, then we move on to hysteroscopy. And we would like to make sure that the gestational carrier exhibits a lining that's trilaminar and, for me, at least 8 millimeters in thickness before we proceed. If for any reason she doesn't achieve those milestones that we're so obsessive compulsive about, then we do a mock cycle, an ERA, an endometrial receptivity assay, and yes, we would do cultures as well. So we would do everything that we possibly can to make sure that her lining is as receptive as it can be for an embryo transfer, because of course we've worked so hard for our embryos. We don't want to waste a single embryo.
We do the same. So one thing is that we do the same here, but not the endometrial receptivity assay. We don't do it at the beginning, but if we have some kind of concern of the endometrium, we do that test, okay? And also the microbiota, we check it also.
As well.
Do you know, doctor, what are you talking about all the time? You are talking about all the time about telemedicine, telehealth. It's nothing. how you say in English, telemedicine or
Telemedicine, yes.
telemedicine. This is just but telemedicine. After the pandemic, we know that telemedicine is we used to do it for decades. So I was working in Madrid before, and we had so many patients there coming from Italy, and I did the same as you. I just ask the report, the test I want them to do. Then I have a meeting, video meeting or a telephone meeting. They would check everything, and then the husbands, they normally come to freeze the sperm. And when we have everything arranged with the donor, I'm talking about here about egg donation, all right, and transferring to the mother, to the lady that is going to have the children, the treatment, not surrogacy, okay? And it's the same thing. You are talking all the time about surrogacy, and here in this world, distance, they are not important anymore, okay? So even in California, which is quite long from Europe, how many days do the parents, you are talking about two things, right? If the intended lady provides the eggs, how many days does she has to be there in the States, in California?
So there are some things that she can start in her home country, but it's better if she can be here for the entire stimulation if possible. And if that's the case, it's about 2.5 weeks. Not everyone is able to do that, in which case we would have them start some of their injections in their home country and then travel to the US. So, we make their calendars on a case-by-case basis, depending on what they're capable of doing and how long they can travel. When it comes to the embryo transfer, it's the same thing. They can start their injections in their home country. We make a calendar. We ask them reasonably, how long can you stay here? And we try and accommodate them as much as possible because, this is a very long journey. It's a hard journey for some. But, our responsibility is to try and make this as easy as we can for them. So we work with our patients to try and come up with a calendar that works for their schedule, for their work. And sometimes, if there's a partner, they'll come with a partner, or the partner will come halfway through the treatment. Basically, we do what we need to do to make this work for the couple or the single person.
Mm-hmm. Okay, perfect. One question. What catheter do you use? I'm just wondering. I use the Wallace catheter.
No, I don't use a Wallace catheter. I used to use a Wallace catheter. I've switched to, it's made by Cook. I use a Guardia catheter. That's now my favorite.
It's Cook, from Cook, right?
From Cook.
Okay. I'll tell the people here in Cook that they are very interested. Why California is so different from the other states? But I want people to know that this is not the states is not the same according to surrogacy, right? Why California is a special place, I think, in the world. Okay, no, it's a special oasis from doing this kind of treatments without any kind of problem.
Yes, excellent question, and I think that's the heart of the matter. Why so many people come to California. Disclaimer, I'm not an attorney. I don't pretend to be an attorney. Our patients work hand in hand with attorneys throughout this process. But California has very liberal laws as far as who it considers to be an intended parent. So the intended parent doesn't necessarily have to have a genetic association with the embryo. So, for example, the embryo could be made of donor sperm. It can be made from egg donor, and it could be carried by a gestational carrier. And the birth certificate of the baby would, in California, have the names of the intended parent on there. And that's why it's really important as part of this journey. It's not just the medical part that we do, It's also the legal care that is ongoing with a US attorney who also works with an attorney in your own country to make sure that everything else is taken care of. So, whereas we physicians take care of the medical part, there's a team of people taking care of you. And this team of people includes attorneys to make sure that, once your gestational carrier is pregnant and she delivers, everything is taken care of. And hopefully you won't have any issues when you go back to your own country. But that's the primary. So there are some states, for example, in the US, where they would not allow the transfer of an embryo into someone who doesn't have a genetic relationship with the embryo. And of course, that's not the case here. And as I said, I think that's why California is like the hotbed of fertility treatment, especially when it comes to egg donor cases and gestational carrier cases.
One very important thing that I think is quite to take into consideration is that the baby born has the citizenship of the state. So it will be nationality of the states and also the country from the intended parents, right?
So as I said, the attorneys take care of all of that. They take care of making sure the birth certificate is issued in the name or names of the intended parent or parents. And that is the basis of obtaining a passport for the baby. So yes, there will be a US passport, and then they will work with the attorneys in your own home country to guide you down the path of what needs to be done from there.
I think one of the group of population that I don't know, if you are a gay in Spain, if you don't have money, you can get pregnant. You can have a baby. So we call it structural infertility. So it's not infertility in the medical way, but it's a structural infertility. Two people two men that they love each other, they can have a family. So that is why I think that it should be legal. I don't think it's going to be quite soon, that thing. All right. In the case of of men, they don't have to go there to stimulate themselves. Obviously, it's just
Correct.
But you prefer to go to the retrieval of the eggs to be as much. I will presume that you will prefer the couple to be as much more possible time with you in the States, right?
So
What is the way you recommend them to do it?
So we're talking about a gay couple.
Yeah.
So they don't necessarily have to come to the US. With especially during COVID and after COVID, everything has been made a lot easier out of necessity. It is possible for men to have their semen analysis in their home country, have the sperm cryopreservation or freezing in their home country. And there are special companies that transport sperm, eggs, or embryos across the continent. And we can have their sperm shipped to us here. We would still do all of the telemedicine visits that we typically do. So at least there's some connection. Other people would like to come and see the center. They're more than welcome to come. And, a disclaimer, San Diego is one of the most beautiful in. So you can use it as an excuse to vacation. I always say when you come back to pick up your baby, so this is a baby that we've created in our lab. I would love to see that baby and be able to hold that baby before you take him or her back to your own country. So, that's something I joke with my patients. I have to get to hold my baby because, he or she is just as much my baby as it is your baby. So, and we do it both ways. We have patients who come to San Diego. They would like us to do everything for them, from the analysis to the sperm freezing. And we have other patients that are so busy that it's very hard for them to travel and to come to the States. And, California, of course, we're on the West Coast, so we're a little further away from our European patients, but definitely worth a visit. And we go with however you like to do it, however the patients like to do it. And again, it's back to accommodating things for our patients to make the journey as easy as we possibly can for them.
Yeah. So they are going to stay alone. They're going to have a very intense connection for the rest of their lives with you, the center, California, the States, because I think the child that they have willing for a long time is being born because of you. So it's not only the place, it's just the connection that you have to. Okay. And we are talking here about medicine. Okay. When people, they say here, just they say when we do treatments from people that they come from because we are in an island in Mallorca, they come from the mainland, from Europe, from Italy, for Germany. They call it tourism, and I don't like the term. I don't like term tourism, medical tourism, or I don't know. I just do medicine. Okay, you have talked all the time about telemedicine. We check the sperm in the country. We can make the sperm be transferred to the States, but it is only these companies. People, they have to know that no one UPS. I don't know if UPS has a special brand of this, but this company is not a normal, regular company. It's a company that is specialized in transferring these gametes and embryos. For example, special contenders, and also monitoring of the temperature all over the time that the content, how you say in English, the contender, the container is transferred wherever. So we do this kind of also in the Spain. So in Spain, of course, we do a lot of treatments here. So it's medicine. We are talking about medicine. No, but also you can see here how beautiful is San Diego and how many things you can do in San Diego. Okay, it's not a problem, but we are talking about medicine and doing things properly with a very, very high, okay. We also have even 70% chances of getting pregnant when we do the PGTA test. Okay, we normally don't do PGTA when we do egg donation. So you do a lot. Just you do everything to ensure that the pregnancy is going to be as healthy as is possible, and is to ensure it as possible, right?
Correct. And, I think we owe it to our patients. That's the most important thing. Whether they're local patients or international patients, it's really about maximizing every single step in this journey to ensure and maximize the chance of success with the first embryo transfer. Because if that was me, the patient, that's what I would want for myself.
Yeah.
So naturally, that's what I would want for my patients. And it's not about cutting corners. It's about the highest standard of care that we can possibly give you to ensure that this dream of having a baby comes true.
This is 21st century treatments, medicine, right? 21st. A friend of mine, Gorka, says, I love PGTA because it's the 21st century medicine. Okay?
Absolutely.
And you can choose the sex. Someone can ask sex. I can tell you, okay, I have my boyfriend, we want a girl. I have 2 boys. That's what I'm asking you. I would like to have a girl, and I don't. Yes. Can I do that?
Certainly. So there are a lot of patients who come here for family balancing. They have a certain gender and they would like the other gender. And of course, as long as we have genetically normal embryos of that other gender, we can do the transfer. For other patients, I always say if the gender isn't an issue, it's always best to pick the best quality embryo to go back first. And if you come back for baby number 2, and at that point you wanted to choose the gender, then by all means. But in order to maximize pregnancy rates, it's preferable to pick the best quality embryo. going back. But yes, we have a lot of patients that go through IVF, PGTA for gender selection. I'm sure we will continue to have a lot of patients because it's a very interesting point for parents to make sure that the legacy they leave behind is of the gender that they would like.
Yeah, okay. No, I understand. And the cost, doctor? I don't want you to tell me exactly the cost, but please, the range between what we are talking about, between 150, 100, how you say, 150,000 to 200,000, more or less. Can you
So
explain us how is?
correct. So average is about 150,000, I would say. And the medical part, the medical treatment is not the biggest expense for the patients.
Yeah.
The biggest expense is actually the rest of the care that they get from the agency, compensation for the gestational carrier, the legal fees, the insurance for the gestational carrier, but all together, and it all also depends on which agency you go to. They each have their own costs. Average about 150. It can be as low as maybe 120, 130, to a high of probably around 200. But again, this is a range. It depends on where you go, the services that you specifically ask for, specific things that you may want to have in your contract with the gestational carrier. And that's why it's so important to have the attorney, and you will have your attorney, the intended parents, the gestational carrier will have her attorney, so there's no conflict of interest. And that's why the contract that they draw up for you is so important, to make sure that everything that you need is in there. And to me personally, the easiest part of all of this is the medical treatment that we do.
Yeah, I agree, totally agree. When I'm thinking about lawyers, with respect, that's not my profession. I would never be a good lawyer. I don't know if I'm a good doctor, but good lawyer, never. Okay, we are ending here, and thank you very much, doctor, for having me, for helping people in Europe that they are trying to conceive through surrogacy in the States or wherever, because this is going to help them wherever they are trying to do this in, of course, places that they are with top level medicine. That is the center that we are talking about, your center, and nothing else. Thank you very much. It's been a pleasure. And all the audience, if you like the content, just put an orange heart, nothing else in the comments. Just, I will notice that you love us. Thank you very much, doctor. And we will have another meeting in the future, probably. Okay.
Thank you very much for having me, Dr. Gomez. My pleasure.
Bye-bye.
Bye-bye.